Right.
Sounds like
Yeah.
it'll always be shifting
Even
masses.
if it's a little way, for some reason, it feels on you. Like, I might as well. That feels very expensive.
Yeah, because the PPO contract is reaching those, I'm like, I need to talk with someone. Yeah. That sounds great, thanks.
Hello. All right. Good to see everyone. My name is Andrew Ray. I'm a UNC alum. I went to the first UNC healthcare conference 2011, I think. And I think there was like 20 or 30, maybe 40 people there. So this has been really cool to see how this has evolved. Thank you all for being here. We've got an awesome panel here, and I'll let them introduce themselves. But I think you all probably know, but we're talking about price transparency here. And I think we'll have a really good discussion, and we'll plan to use roughly 35 minutes or so with a few panel questions, and then open up for a few audience questions at the end. Okay.
Hey everyone, I'm Lindsey Klein. I'm the Chief Strategy Officer at a company called QGenda. We do healthcare workforce solutions. Have been in healthcare IT for the last 20 years, mostly on the provider side, but also spent a lot of time on the employer benefits side, which will be part of the discussion we talk about today.
Hello, I'm Steve Shelton, Vice President of Contracting with Unified Women's Health, and we provide MSO or back office solutions for the largest group of OBGYN providers in the country.
Jacob Conitzer, I'm an associate principal with ECG Management Consultants, focused exclusively in the healthcare industry. Have done a lot of work with payer transparency over the last few years, ranging from network strategy to developing competitive intelligence solutions to using it within managed care contracting negotiations. So good to see all of you.
Great. And I'm my background, I'm an associate partner at McKinsey. Similar to Jacob, do all my work in healthcare, working with providers on a range of kind of top line financial topics. All right, so our overall prompt here that we're going through is, what are the most significant challenges with price transparency? Where do we think it's working? Is it working? And what do we see the opportunity to be? So that's kind of our overall prompt here. But the first question that I'm going to kick to Lindsey is, how can healthcare providers and insurers work together to ensure that price transparency leads to actual price reduction? And then how do we factor in quality? And how is that impacting across different sites of care? So I guess really three questions, but yeah.
So just to level set, and I think most of you probably know this. So over the last couple of years, there's been a lot of legislation passed around price transparency, right? The No Surprises Act, the Transparency and Coverage Rules. And the ultimate goal, the objective of those is essentially to reduce prices for all healthcare consumers. I think we've seen some positive movement, and maybe less so than we would have expected at this point, largely because the burden of the price transparency rules in order to make those prices more readily available to consumers is really on the payers and the providers. And frankly, other than the biggest payers, it is a big task from an IT perspective for providers and payers to comply with the rules. So most folks to this point have done kind of the bare minimum, which is hospitals have somewhere on their website where they've put their prices. Now, I use prices in quotes because anyone who's done any work in hospital revenue cycle knows a hospital charge master is probably one of the most convoluted price books you've ever seen in your entire life. You've heard some of the stories about Tylenol cost $200. Well, it's not really $200, but there's been a lot of convoluted markups over the years because of the way insurers have paid for healthcare. So insurers typically pay a percentage historically of the charges that a hospital bills, which is why hospitals have to mark up their prices. Anyway, that's a long way of saying until we kind of fix the underlying, the way we price services being really equivalent to what they ultimately cost with some markup, it gets really, really complicated. So CMS just came out with a new round of rules, basically saying, like, we want your prices to be published, not based on your price book and your charge master, but kind of based on a set of rules that we create. So I would just say that I think, you know, we're making progress, but we're also recognizing why this is so hard. And the last thing I'll say, and then we can, I'll add some stuff later, but really the biggest differentiator, what we've seen when we've priced out services historically, is site of care. So not to pick on the hospitals, because there's lots of services you only can get in a hospital, and you should. But if there are services you can get outside of the four walls of the acute setting, that tends to be cheaper and often actually better. So we've seen scenarios where an orthopedic surgeon will do the same surgery in the hospital, and the same surgery in the ambulatory center. And in the ambulatory center, it costs about a third to a half of what it costs in the acute setting. So that's what I would just say to consumers and hospitals is we have to find a way to bring those disparities more together. That site of care does not create such a wide difference in price.
Steve, Jacob, anything to add there?
Yeah, a lot. So I'll try to be careful and talk through which stakeholder angle I'm kind of viewing this from, right? Because work with payers, work with providers, hospitals, academic health systems, physicians, and I think I left consumers out, but that's maybe purposeful. I think we'll get to that though. But no, I think even it's the movement with price transparency, and I think it's happening, is really interesting. And I think we're going to see like a lot of unintended consequences as a result. And even Lindsey talks about transitioning care into like an outpatient setting. What does that do to hospitals, right? You might be moving high margin services into a lower cost setting. In a rational market, prices would have to adjust up then for the hospitals to make up for that margin that's moving out. We'll talk a little bit about if that's happening or not, or if we even have the tools to make that happen. But yeah, looking forward to getting into this and kind of talking through some of those consequences we're seeing.
Terrific.
Sure. I actually will tackle some of the consumer side of it since you left that open. The transparency, when you look at it straightforward, it makes perfect sense. We go to the grocery store and you see a couple of peanut butters and you say, okay, I'm going to take that one. Sometimes you choose Peter Pan. Sometimes you take the grocery store or Jeff. But when you put it to healthcare, as Lindsey said, it's a little more complicated. In theory, yeah, sounds perfect. But when you go to the hospital or go to the doctor, you can price out, so, okay, what's an office visit going to cost? But then you get in with your diagnosis and they say, well, you need an MRI, or you need this, or you need this additional test. Well, are you going to pop out your phone and look it up real quick? You're kind of going down a diagnosis path. So you're trying right now with transparency. We're at the first step. All of these things are possible. And we're going to be discussing a lot of the different steps along the way. But I think that's where we got to discuss is the intent, and then how do you get there? How does a consumer use transparency to do what it's intended for? And how do the payers and providers all play their part and making it simpler for the consumer? And it's going to take a while because it is very complicated. So we'll start with that.
One thing to add to that, because I didn't answer your third question about quality.
Yeah.
So your peanut butter example is a really good one, which is when you go to the grocery store, right? And we've all become, I think, more informed consumers, even in the grocery setting. You don't just look at the price, you then flip the thing back over and you look at the ingredients. I would say that's kind of similar to quality in healthcare, right? Ideally, we have enough information to know, what am I paying? And how good is it for me? Or what are the likely outcomes, right? We often will pay more in the grocery store for something that we think is better for us, granola with less sugar. Similar in healthcare, we often don't know, is that thing that's more expensive actually going to lead to better outcomes for me as a patient? So I think that's where there's a rub in terms of you shouldn't just be making healthcare decisions based on price alone.
And I want to add one other factor to it, it's access. If you live in a certain region and there is only one OBGYN, one primary care physician, are you willing to drive 100 miles, 50 miles? What is the criteria for a lower price? And are you assured of getting the quality that you're looking for? So there's a lot of different factors that maybe it's not really thought out when you look at transparency and when you think, oh, it should be as simple as choosing different peanut butter on the grocery store aisle. There's a lot more factors that we have to take into play.
I think it's good because price transparency is accelerating these conversations though. And I've seen it come up recently where, you know, in negotiations across from a payer, so from the hospital perspective, you look across the river and you can see that that hospital is getting paid 35% more than you. You have better quality, right? You're larger, you have more physicians, you have a more expensive cost structure. So you're asking yourself, why is this happening? And, you know, I think that is a common question and it's a good one to ask. And we're kind of dealing with that now and reconciling, like, how did we get to where we are with these prices? And it's, I don't know if you're familiar with like the paradox of rationality. And it's where you'll often see the irrational actor have better outcomes, right? And I think that is extraordinarily prevalent in healthcare and how we arrived at kind of the pricing that we see today, where it's so irrational. And there's a lens on it now, and we're exposing it, and we're having these conversations about how do we think about quality? How do we think about access? How does that factor into the price? So I think that's.
Yep. I'm going to focus in on one thing, Lindsey, you hit kind of right away, which is the irrationality of what's actually posted publicly. So price transparency, you would think that I can quickly go and understand, like you do in any other consumer setting, what something's going to cost me. That doesn't work. And so kind of two components. I think first, Steve, I'll tee one up to you and then Jacob to you. But the first is on the more kind of policy and compliance side of, you know, right now it's a very kind of penal process of if you're not posting and you're not posting in kind of some structure that can be machine readable and all of these things, you get penalized. So is that structure of penalty, or should we look at some incentives working? And then how does that differentially impact providers of, you know, small provider sizes versus large health systems, smaller payers versus large payers, those sort of things. So that's kind of topic one on the compliance and enforcement side. Topic two, Jacob, that I'll tee up for you is on the technology side. We were having this discussion outside right before this of basically no providers or payers really understand what to do with this data. There's entire companies that have been created to pull down this data and try and make something useful out of it. So from a technology lens, how can we move the needle to get much better there so that the data is more usable at the fingertips of not only the payers and providers, but hopefully eventually the consumers?
So I guess I'll try to remember the first two
Yeah.
questions. You can maybe remind me. But I believe the first one was, should we have more penalties and incentives? I can tell you from a user of this, looking at it, even large companies, whether knowingly or unknowingly, when you transmit all of the transparency data in, unless you have a similar format and similar constraints, it comes across as junk. And I can tell you from having a team that works on it, maybe Jacob can tell me what's the larger term than terabytes or whatever the largest. I mean, it takes a lot of computing power. It takes a lot of resources to go through and then to find out, oh, that actually doesn't tell me what I need to know. So some are doing it, some are not. But to find out someone's not doing it in a way that's usable takes a lot of time. And then when you get to the end of it, what would be the proper penalty for that? I would think that would have to come into play, but I'm gonna get into the second factor because it actually dovetails very nicely into it. And for anyone that was here before on the consolidation discussion, it dovetails really into that as well. It is actually driving consolidation. So I'm going to use these three ladies here. If they're physicians A, B, and C, small, medium, and large, the small physician maybe doesn't have the resources to actually make sense of the transparency data. They don't have the resources to even comply. So to acquire those resources, they have to really advantage or add expenses, add staff that they can't afford. Now, physician B, maybe he's in a medium, they can get a little bit of it. And when they look at it, they're paid less than physician C, who's with a large group, who has the resources to look at it and can tell these things. So when you look at this scenario, if you did take it back in a textbook or discuss it in a class, physician A really has very little choices except to join a larger group that can help with transparency, to help with all the authorization requirements, all of the rules with doing independent physician. There was an individual physician, I'm not sure if he's in here now, that had talked about saying all the rules they have to comply with, and we're not sure it's decreasing cost. We're not sure it is or increasing quality at this point. Why don't we go back to that system? But at the same time, this is actually how the system had to evolve. So this is a first step, but the first step actually drives consolidation among small providers because they cannot keep up with the system. And I'll go one step further, and that is, how does that actually affect pricing? Well, the thought when you go through this is transparency again, that people will make rational decisions and go to the lower cost, higher quality provider. Right now, we don't exactly have the quality data yet to show this. So then the theory is, okay, you'll go the lowest cost provider. But when you look at it on the flip side, why would the lowest cost provider continue to stay in business when their expenses are rising, their income is not rising? It makes more sense for them to join the larger group that maybe has better pricing and has the infrastructure to handle transparency and all the other regulations. So short term, this actually has the opposite effect. And I'll probably pick on later on why this is still the right step. But short term, I think it may be having an unintended effect.
And Jake, what are you seeing on the technology front in terms of both challenges as well as maybe where could we go? Where's the opportunity?
Yeah, I don't think that anybody's solved it perfectly yet. And I know that we've been trying for a number of years. I think just data quantity, right, is a massive challenge. We were running a script the other day and it's like, you're on row 3,573,000,000, right? And it's just over and over, and you're seeing that in the compute, the resources that are required to handle that. And this is working with a payer, right, and helping them build out their solution. And there's a number of players out there, like you mentioned. There's the Turquoises, the Clarifies, who are solely focused on getting this data into a shape that you can use it. But then there's even, once you have the rates, like how accurate are they? How do you actually price a service? I don't know if you're familiar with outpatient hospital pricing, right? But you might have an MRI done, and you might have to pay for that if you only have an MRI done. Or if you have that in the presence of a surgery, then it gets packaged into the surgery and the price is completely different, right? So how do you even kind of go through these services, reprice them, almost re-adjudicate claims using somebody else's prices? And there's people working on those solutions, but it's really, really complicated. And then you put that in the hands of consumers, individuals. I don't even know where to go with that, because we have experts working on it who are having a really challenging time making sense of it and getting the right answers. But I do think that there's a lot of progress being made, right? We're still nascent, we're early. There's steps being taken. I missed the dinner last night. I was busy reading the OPPS final rule. And it's about as interesting as you might think. But no, they're pushing new standard schemas on the hospitals, on the provider side, that should be helpful and make things easier to just ingest the data. And then, yeah, people will keep taking steps, I think. There's new consumer apps out. I don't know if you're familiar with, or if any of you have seen them, that kind of visualize pricing across different localities and by service. So there's a lot of players out there who are trying to do things, and it's coming. I think it'll take starting root and making a real difference over the next couple of years, but slow moving. It's healthcare.
Yeah.
I'd like to make one point on that on the technology side, and it was the one I missed today, but I do have a colleague that attended it, so I want to ask what the results were, and that's AI, how it will play into this, because of the large amounts of data that are needed and the large amounts that you have to consume and make quicker decisions on. That's going to play a big role. And we haven't gotten to that point yet. It took this long just to get the transparency data out there. Now we've got to make sense of large amounts of data. There is a technology that can do that. How we use that's going to be very important over the next, what do you say, 5-6 years?
Yeah, I mean, I can talk about a little the process that we take, where, right, we ingest all the payer transparency data. We take that, we compare it to payer A's utilization data, and then reprice payer B, payer C, to say who's paying what, in totality. So looking at total price, not on an individual service level. But then we're comparing that to the hospital transparency data to validate it. then we're comparing that to COB data, then we're comparing that to remit data, right? And like, who has all the resources to do something like that? I think you alluded to it. It's, you know, the bigger players, they're going to be much more advanced. They're going to get there faster and figure out how to use it. And that's what we're seeing.
And I think it's a good segue into the consumer side of this. So patients as consumers largely hasn't existed in healthcare, I would argue. It's, you know, started to with a few things around digital health and certain models that have, you know, cash pay and are more transparent in terms of the actual healthcare provider and healthcare delivery, but probably, you know, a small part of the overall cost structure within healthcare. So Lindsey, I'm going to tee this one up for you, but impact of price transparency on consumer and creating a patient as a consumer within healthcare.
I think it's a step in the right direction. So ultimately, when you look at the rules, there's a couple of things, but even before it's just about the price. So the first, one of the main parts is about a provider directory. And what that means is I should be able to go to my payer. So let's say I have Cigna and look up their entire directory of providers that I have access to. And it should tell me, are they accepting new patients? And a bunch of other information so that I can start to hone in on who I want to work with. It may or may not have any pricing information or quality information. Typically, they want to have like, I think the goal is to have like, you know, how we look at restaurants, a $1 sign, a $2 sign, and then like a high quality, a low quality, but we're not there yet. So I think that is a great step in one direction. I think then the ultimate objective is I show up for a service or I am scheduled for a service. And this is where it gets tricky. Emergent services, throw them out the window. Like we're not going to be able to price emergency services probably ever in advance. But if I have a scheduled service, surgery, whatever, I should be before my surgery, ideally multiple weeks, getting a summary of what I should expect to have to pay out of pocket. The hard part is that means the payer or the provider has to know exactly what they're going to do, to a point that was made earlier. And they already have to have talked to the payer about what the payer is going to cover, because the consumer portion is essentially whatever the payer won't pay for. And I think that's where it kind of all starts to break down, is like, will we get ahead of the process enough for that to ever happen? And then for that consumability to be done in a way that people can understand. And then the last point I would make is, I think generationally, we are making a good shift. If you talk to most of our parents and grandparents, my in-laws are staying with me right now, and my mother-in-law will never leave her primary care provider. Like, he will be her primary care provider until she dies. And so it's that loyalty actually sometimes hurts consumability, because you're not able to then go find the best provider at the best price. You're loyal to a fault. But I think the younger generation, what you're actually seeing is they don't even have primary care providers. They're going to urgent care for their primary issues, or like a minute clinic. You know, you hear Walmart and Amazon, like that might be the primary care of the future. But then how do they get connected with the right local physicians when they need something more acute? I think that's where, you know, we have a long way to go, if that makes sense.
Yeah, and I think you hit on a key point I'd love to kind of tee up to the rest of the group here, which is who is responsible for owning this? Obviously, the patients are trying to figure it out across a bunch of different constituents. Is it the payer? Is it the provider? Is it the patient? Is it some other third party? Is it the government? Like, where do we see that going in terms of having a source of truth?
Yeah, I'm actually going to take it even one more direction. The employer.
Yeah.
Most people get their benefits through their employer. And that was one thing I was thinking while Lindsey was doing, because while I'm sitting here, I'm thinking about whole different ways to draw up the healthcare system. But part of that, when you think of transparency, you think of, again, a rational model, when it's really irrational, because the benefit design drives most of the consumer decisions. I just got my benefit plan this week, and I looked at it, and I'm looking at not the providers I go to. I make sure they're a network, but I'm looking at my deductible. I'm looking at my out-of-pocket max. I'm looking at the cost of the premium. And then I know at a certain price, I go beyond all that. And then I don't care what the cost is. I can use the healthcare system however I want. I've got a free ticket. And so when consumers have that free ticket, there is no incentive to care about transparency. When you have high deductible plans, I think most people are used to seeing that now somewhere in your package, and you have your HSAs and you have things that you can use. It's a step in that direction, but is it enough? So one thing we're also going to have to look at is how do you drive rational behavior? I think Jacob brought that up before. This is an irrational behavior, but it's brought on by a lot of things that Lindsey mentioned as well, and access. That if you have a provider that's on your way home and a provider that's 30 minutes away that may be $50 cheaper, what's it worth to you, and a provider that you feel comfortable with, their bedside manner, knowing that you're going to hit a limit, and then after that you've got free access to the whole healthcare system. So there's a lot more in play here.
Yeah, to try circling back on your question around who should own it, right? That's a tough one. I think payers are definitely the best in the best position to own it, right? Because they have the most data, the most information, and probably the easiest means to distribute that out. But there's probably trust issues, right? And so I hate to add another stakeholder to the game, but I think there's another party that comes in and kind of owns it and is viewed as that source of truth that works between all the various stakeholders. That's kind of how I see it shaping out. And then on the consumer side, yeah, I'm more pessimist than anything there. I don't know how many consumers or how many patients actually want to be consumers even. I think I've seen statistics around how many folks understand, what coinsurance is, what a copay is, what a deductible is. It's like a very small percentage of the population. There's definitely pockets of people who are going to want to shop for services. That's always going to exist, right? But mostly they just want to know, is this affordable? Is it high quality? And almost stop there. And that's kind of where I sit at with this. And that's not discouraging on the future of price transparency, because it's incredibly valuable still. I just don't know how we get to the consumer angle at this point. I don't see it.
Yeah, I'm going to circle back because I feel bad now. I didn't answer your question. And that is, I would think in a logical world, and Jacob brought up the best answer probably is because of trust. Neither of the sides right now trust the other. So you would have to have, and so when my dreams of building a perfect society healthcare model, it would need to be a government type agency that every flows into, and then they're posted. And anyone can go out. So payers, providers, consumers can go out there and see that and hopefully be trusted, maybe at the state level that you say across the state, here are the different pricing, the different average costs for diagnoses, different things here that we would have to work on and see what would make the most sense. So because of trust issues, I would see that as the best solution.
And to try and end us on a probably more optimistic note here, I think we've talked for 30 minutes about what's challenging, what's not working, those sort of things, but particularly keeping in mind the students we have in the room and the being filled with hope of a better future, and certainly helping us drive there. What's the optimistic view of this? Where is it working right now? And Lindsey, maybe I'll kick that to you.
Steve hit on a point that I think is really astute, and it is on the employer side. So I actually think you're starting to see employers be much more thoughtful and proactive about benefit plan design for their employees. And right, that's where the bulk of healthcare gets delivered. The employers are providing the benefits, and then we're the consumers underneath the employer umbrella. So I think what I've been really pleased by is, and something we really haven't touched on, is the way you drive down prices is prevention. And wellness programs are, I'm not that they haven't been a topic, but I think real focus on preventative type programs and services, even virtual visits for PT and things like that. One of the most overutilized services in healthcare is MRIs by far. And we've done tons over the last 5 years to try to reduce the use of MRIs. But one example is a lot of more virtual orthopedic consults, virtual behavioral health consults. But I'm even seeing employers create overlay plans on top of the insurance network that is just the providers that have high quality and low cost. And they're basically saying, like, not every employee is going to love it, but we're going to narrow your network. And if you want that high deductible health plan, that's fine. But you can only go to these physicians who we have blessed as ultimately being lower cost and higher quality. So I would say we're starting to see the employers actually lead that charge as kind of the middle person who can help really move the needle on all of this.
Yeah, I would say I brought up this example before saying short term, actually, you should see a rise in prices because what happens, the people that are being paid more would say, oh, we agree, we're going to take a 30% discount. It's more of the people on the lower side moving up to the higher side. But then when you get a little bit further, if you play the model out, once everyone kind of equalizes on prices, then you start to see quality differences, different model differences. You'll hear the terms value thrown around. Payments should be made probably for quality bonuses if you hit certain quality statistics, whether it's HEDIS or different things you may hear about. I would think that would be the logical step once prices equalize in the market. So we're at early step. There's going to be some rumbling, consolidations. There's going to be rising prices, but then it should hit a level if it's a rational model, which we've proven it's not. But in theory, it should hit a level that quality plays a much bigger part, and hopefully you get more value from the system that way.
Yeah, I hope I didn't come off as overly pessimistic because
It's realist.
but I am extraordinarily optimistic on what it's doing. And I think it has to do with finding that market equilibrium, and you're seeing it play out in payer provider negotiations across the country, where you're coming to a difference and you know what your competitor is getting paid and everybody knows what you're getting paid. And then it's like, well, what do we do about it now? And nobody has that answer. So I think that's some hopefulness too for students. It's like, help us figure that out. Like, what do we do about it now? Help payers, help providers figure it. They don't know where to go with that conversation. It's like, okay, well, we'll turn Medicare Advantage in because we need higher rates in commercial, right? And it's like, where should we focus? What should the conversations be on? And there's, you know, an entire model that's going to be constructed over the coming years that addresses that question. It's just like, what should price be based on and how do we figure it out? And everybody has a different opinion on it, but that's what I'm super optimistic about, is that we finally get to have those discussions, and we don't get to have the discussion where irrational behavior leads to the better outcome, where it's like, oh, I want a 20% raise and I'm not backing off of that. And it's like, an irrational actor, you just have to give eventually, or they go out of network, right? And we've lived in that world for the last, I don't know how many years. And so I'm excited to move away from that and have actually meaningful conversations that I think can change the future of healthcare and how it's financed.
And I'll say this belies my age, but 32 years I know I've lived in it, so it hasn't changed any. I think that's an excellent way to end out. How are you guys going to solve this? We've told you what's coming, and you guys are the next generation. So how are you going to solve this?
Yeah, I think one interesting model to hit on, and then we'll open it up, is like you look at Walmart to the big employer model. Like they've developed some COEs around spine surgery and cardiac care and things. Well, they'll fly their employees all across the country to say, here's the place you're going to go. It's cheaper. We're going to get better outcomes to pay for all this travel costs, focus into a couple of areas. Like that to me is a very interesting model. There's not, other than maybe Amazon, any other employers that have the scale to do that. But if you think about a regional model.
To give them credit, Lowe's in Charlotte actually was the first one to do that with Cleveland Clinic for heart procedures. They actually did that like 10 years ago. Unfortunately, the data has not borne out positively in terms of cost reduction, but you know, I think it's a nice thing for employers to be thinking about.
Yeah, definitely. All right, so we'll open up to questions. Yeah, I can run the mic real quick. Yeah.
Thank you all for being on the panel. My question in general is, if you were to, I guess, choose of the three or maybe add your own, what would move the needle, so to say, to kind of on the consumer lens, to really help with transparency? Is it technology? Is it policy? Or, you know, I guess the third one would be, is it just better consumer knowledge? And feel free to add your own. Thank you.
It's a tough question. I honestly don't know. I don't think policy is ever the right answer to drive behavior, just personally, you know, and I say that having lived in DC for 10 years and Jacob lives in DC now, but, you know, I really do think it is how do we teach people at a young age that you are in charge of your health? And I think we've all somehow grown up to think like, oh, well, it'll take care of itself. Like someone will make me better and it'll be fine. And I think we've tried for a long time to increase incentives around prevention, but I actually think like it kind of starts there. Like, how do you put people's personal health care in their own hands? And we haven't gone as far as I would like to see there. But then when you do have an acute problem, like how do we give people a roadmap for what a healthcare decision should look like? I still think like we don't teach those skills, just like we teach financial planning skills. I don't think we teach health ownership skills. And I actually think it starts with education at a much younger age.
Yeah, I'm probably going to go a different direction as usual. I'm going to go back to the way benefits are set up. As I said before, and I'll relate it to an example because it always helps me think through it. So if I went to the grocery store and I have $20 to spend, I'm going to pick the cheaper items to fill up my cart. If I have $100 to spend, I'm going to take more expensive items. But what if I am told after I spend $20, I can get anything I want out of the grocery store? Well, I'm going to put $20 and I'm going to fill up my buggy and go through things. So I think to drive consumerism in this, and I've thought through it a lot, the high deductible plan makes a lot of sense. You have to put a lot more in the consumer's hands for them to drive the correct decisions. So at the beginning, that seems like tough because if I had a company and I went to all the employees and said, okay, I'm replacing your plan with a 10,000 high deductible and maybe a 15,000 cap. Well, I know that's going to drive my healthcare costs lower because they are going to live with that, but I'll probably have no employees. So I would have really a low cost. So you'd have to combine that as to part of your pay raise. So you get, instead of, I'm gonna pretend I make a certain amount of money, 50,000. And if I get $50,000 and said, okay, this year you get 65,000. And you can spend that. Here's the health plan you have to use, and whatever you pocket, you can save. They're going to look a lot more at the tools then, because that's part of their take-home dollars instead of this mythical HSA account. So what I would say is a radical redesign, but I don't see any other way to get consumers to actually take it seriously and to move the needle to get to that way.
I would cheat and say all three, but I think that if patients, if consumers want that, they're going to be able to get that through advancements in capabilities. So I think technology is kind of going to win that one, and be the leader, but only for those who want it. So like, is that a big enough population to get the investment that's kind of required to produce those capabilities or get them to where they need to be? So.
Hi, so maybe we need to change the conversation, because why are we putting this all on consumers and focusing on consumers? We're actually not solving anything. We're just giving more hurdles, because we started HSAs, 15 years ago? That they don't have much more uptake. Everyone wants a PPO. We started putting price transparency, but who's the price transparency for? It's not for the consumer, because based on where you live, your benefit design, your income, and really like 50% of the healthcare dollar in the US is controlled by the government and not the commercial market. So who's controlling it? It's not the consumer. And this focus on the consumer actually minimizes our ability to find a solution. So when we take the consumer out, what does the market look like then?
Yeah, I think that's a great way to kind of summarize that. And I agree with you completely. I think though the market, if you take the consumer out, I think is the question, like, what is the market and how are decisions made and where is this happening at? Yeah, and it goes back to how our price is set. And there's a long history there that you could kind of go, you could have a course in a semester that covers that. But, payer and provider, right, negotiate rates that largely revolve around not even the individual prices of services, right? You're not talking about what is an MRI cost, what is a surgery cost. It's, we do $100 million in business with you, and we need that to increase by 5% to cover our costs, right? That's the level that a lot of the conversation happens at. That's how it's done. But I think price transparency, right? Services, both parties then providing, kind of eliminating the information asymmetry that's existed to date, where there's more perfect information so that you can actually act rationally. Because previously it just benefited folks who would act irrationally. They'd be in those discussions talking about that 100 million and say that they need 150 million, right? And that you look across the country and there's, like I said, there's a lens on it now. It's been exposed where you see that they've gotten in certain cases and you're like, what, how did we get here? How did this happen? And now how do we fix it so we can have those conversations about fixing it? I hope that kind of answered the question. I don't.
I actually, because I was saying more on the consumers, I'll respond to that. If you take the consumer out totally, then you have a national healthcare plan. So that would be the solution if you're going that way. But from studying, the UK model, actually, which I just finished doing, then you have long waits because the consumer then can utilize the healthcare system as they want. There's no price concerns then for the consumer. Everything is solved. But when you have that, are you willing to trade off the choice and the access that we have currently in the system? So if you take the consumer out, that is the result, and that is a solution. And it's certainly a solution that everyone looks at, but you take away a lot too. So you have to consider the trade-offs from the type of system we have here versus the type of system they have in other places.
Agreed. The only addition I would add to that is to be a little bit fair to the hospital side, I think they are trying to reduce their overhead costs. And you see a ton of data out there about the way AI can be used to reduce the time it takes to document, to bill, right? You're not wrong. It's actually 60% of every dollar spent on healthcare goes to administrative overhead. So that is the core of why healthcare is so dang on expensive in the United States, is because it's not efficient in the way it's delivered across the delivery mechanisms. I think the reason we are talking about consumerism in healthcare is because when you look at the power of the consumer, look at Amazon. Consumers showed that their desire to shop in a different way drove the success of Amazon, which changed the retail landscape completely. So I don't think anyone's saying the consumer has to fix this. I think what people are saying is the power of the consumer creates faster change than will occur by payers and providers left to their own devices. That's what people are saying. Oh, agreed with that 100%, but I think it's both. I think it is the employer and the consumer as a unit, because employers, sitting on a board, a number of boards, like employers think about the benefit design based on how their employees are going to react to that benefit design. So they're so afraid, especially in a workforce shortage, that if I design a benefits plan that is more aimed around cost reduction, my employees will leave and will go somewhere else where there is a better benefit plan that employees see as better. So I don't think you can say the employer needs to design a more cost-effective benefit plan, because I think the employers are scared of the outcome of that design in terms of employees leaving the organization. So that's the only other argument I would make.
So y'all were talking about the quality and value, and what that exactly means is, they're very pretty words. But how do you all see the value or outcome measures playing into the transparency of cost? Because like to the woman's point back there, their health outcome data in the US is not fantastic compared to other Western countries. So, but our cost is one of the highest. So there is something to say, like, yes, wait times, no, I don't want to wait for forever. And when I'm looking at value-based or quality care, I want it to be those higher quality life outcomes, as opposed to did my physician document in the right flow sheet row in Epic?
Yeah, I'll take the first stab at that. And that is, as I mentioned, what I hope to be the second stage of the transparency, that first, there's going to be an equalization of pricing. It has to happen through consolidation, negotiation at some point. But then when everything's equalized, how are decisions made? And I'm hoping that the second point that goes out on websites or wherever manner it's distributed is the quality. And I work a lot in a maternity and see those quality statistics. I would love for the physicians to have to post, here is their maternal mortality and the health of the babies. Those should be things that are posted and agreed upon quality measures. And if you leave the industry to it, it's going to take a while. So it may take a push from somewhere. But I think that's going to be the differentiator in the future. At least that's my hope.
If I let my cynical side talk, I'd probably say marketing dollars will kind of be the gap that fills that. But no, I agree that we get there. I don't know how to define quality. Agree with the pretty words. I do think though, you just look at kind of what value is, and then you often get that formula like cost divided by quality or quality divided by cost, whichever way you want to look at it. And so I think you probably default back to that, and we figure out then what quality is, and that's probably unique to individuals, to patients, and give them the information to make those decisions.
I would just argue, I think policy does play a role in the quality piece and advancing the quality agenda, because as someone who's done quality benchmarking, I can't tell you the number of times that data has been presented to hospitals or physicians and they're like, that's wrong, or there's an exception, or, and so I think like you're always going to get argument about, until there's a policy about what quality means and how it's measured, I don't think anyone will ever be on board with the term quality and like how they define it. So I think that is a place where policy could get a lot better, because our policy measures around quality today are pretty darn terrible, to your point. Like patient satisfaction scores, to be honest, mean nothing. And like a lot of the outcomes measures we're measuring are really convoluted measures of outcomes, right? So that don't impact the consumer in many cases at all. So I think that is, to one question asked earlier, potentially like a point where we can have quality play a role, or policy play a role.
And I think we have time for one more question. I'm gonna run up here, but just an administrative note while I'm running up the stairs. We're gonna break here at 12. We've got lunch outside. And then 12:20, we'll be back in here for the Dean Speaker Series. Go. Yeah.
Thanks. So we talk about quality, preventative care all the time, but if we lower somebody's blood pressure at 30 and then they don't have a stroke at 70, the employer doesn't really benefit from that, right? So, which is one of the problems with preventative care. It's great for the individual, but with people switching jobs every X years and then on Medicare at 65, the question about preventative care, while good for society or the individual, there's no value proposition per se in the immediate future for the employer. So that's one point. And on a totally different note, as a clinician, the whole RVU model is screwy when you think about a brand new lawyer doesn't get paid at the same rate as a guy with 30 years experience. And yet an OB who's brand new, if he's got a better contract in his system, gets paid more than a guy with 30 years experience who delivers better care. Whereas in another profession, you might increase your fees by 50% and do half the work and make the same amount of money. In medicine, it doesn't work that way. And so the system's fundamentally broken from that perspective. So those are my two comments.
I'm gonna take the first one. I got sidetracked thinking of your second one. So first point on the employer, I agree 100%. I've thought through that question a lot, and that played into what I said. My ultimate think is that you'd have to go back to the consumer, and you kind of take away the benefits and say, it's part of your salary, you get X amount we're adding on for your healthcare. And then if everyone goes to the exchange, which now the exchange exists, then the benefits you reap as a consumer or as a user of the system do play out over time. The decisions you make now stay with you. You're managing the money and how to use the system. I agree wholeheartedly. It doesn't make sense in the current system for an employer to make a contribution on preventative care because they're not going to reap the benefits. The same thing for even a health plan. I've thought through this and said it's the right thing to do. But if you go back and look purely from a clinical, well, I shouldn't say a clinical, purely from a business side on who's going to reap the benefits, it's someone way down the line. So it borders on an ethical question, but if I think in business wise, how would I address it? It would be giving the power back to the consumer and not have the employer control benefit plans. Say, here's your money, you control it, you control your future, you can make your decisions as you see fit. The second part, I don't have an answer for the second one. I may have to turn to Jacob.
I was thinking about the first one, so no, I think you're opening a whole nother can of worms there too. We talk about consumerism, right, and having the ability to make decisions around prices. I think you get into, the case you used was 30 years old and then 70 years old, but preventive care fits a lot of needs in between that do kind of cover, I think, and incentivize employer contribution to benefit themselves where they get rewards. But I think if you're talking consumerism, right, you're also talking like lifestyle choice, and maybe there's ways that you move or create models that incentivize lifestyle choices that accompany preventative care. And you've seen employers do those types of things,
For
right?
sure.
So that's kind of my thoughts on that one after hearing y'all talk.
On the first point, just one addition, and then actually the second point's an interesting one. On the first point, I do think, to the point Jacob's making, you have to make a bet as an employer unless we change the entire benefit system and move to exchanges where the employer is kind of out of the equation. You have to assume, though, that over time, if your employees are doing preventative work and going somewhere else, you're also getting employees that have been doing the same thing, right? That all employers are acting the same way, which we know isn't true. But if you think about it as employers, the biggest thing you're probably spending money on, depending on your employee population, is medication, drugs, right? So we haven't even talked about the pharma piece of all of this, right? We've talked about the healthcare delivery system, but another big reason US healthcare is so expensive is pharmaceuticals. And we've done a lot in that space, as you guys know, over the last few years. But when you think about the employer side, the biggest spend most of the time isn't on surgeries. It's on high cost drugs for your employees. So that's just something to think about there. Is your ultimate goal is reducing the amount of employees that need to be on high cost drugs because they don't have chronic issues like diabetes, heart disease, cholesterol, high cholesterol, et cetera, right? Like that's where most of employer spend for healthcare comes from. On your second point, it's an interesting one. If you're the employer of those physicians, though, depending whether you're UNC, who employs physicians a lot yourself, or whether it's a large physician group, all the employer really cares about is your throughput of patients, because that's how they make money. And so until we change that dynamic, it's not going to matter whether you've been in the industry for 80 years or 5 years. If your throughput is higher for your employer, you're making them more money, thereby they're going to want to pay you more. And so I don't have an answer for you. That's just the way the system is designed. It's not great for consumers by any means, but that's the issue at the core of what you said on your second point.
I'm going to take one shot at the second point because that is a very difficult question. And I had a cynical part of point one, but I think I'm going to leave that alone for now. So on point two, how would you compensate differently? It is a possible through consolidation that maybe there would be a model that if the group comes together, they decide a physician on year one, how they get paid differently and how it graduates up. But I would make the same warning that I would make to an employer group that maybe Jacob advises, saying, if you're building a benefit plan that works like that, you're competing with maybe another group that's trying to recruit the same physician. And if they offer the same salary, they're going to get that person, and then they will grow over time and crowd out yours. But I think you can, as a group, make rules like that, and it can be graduated salaries. I don't know if I would base it off of years, but definitely quality. And I think maybe someone starting out should have to prove quality and have certain results over years. So I think that could be a model, and I think it'd be an interesting model now that I think about it a little bit more. But it's the same thing as Lindsey brought up. I'm going to go back to that cynical point. I can't leave it alone. As far as benefit designs from employers are employee retention devices. And so you have to compete with other employers, and preventative right now is where you compete. You have to add those in because that's what everyone else has, and you want that employee, even if you're not going to reap the results. The same thing flows into your second question of, okay, you can have a model that pays physicians differently based off of years experience, even based off of quality, which I think would be a novel way to do it. But it is a competitive market that different groups are competing for physicians, any other type of provider. And so you'd have to take that into effect when you draft those policies.
And just time check here, I might invite us to continue the conversation as we move outside, but very much thank you to Lindsey, Steve, and Jacob for their time today.